Thank you, Omar. It's been always a great session, as always. So my talk has financial disclosures. Probably all of these companies have some relation with this talk. This is a patient that comes with fairly high myopia, asking for laser vision correction, and topography is normal. Central corneal thickness is a little bit towards the thin side, but we decided, even though we had a pentacam with a D and an artmax that were kind of borderline, our artmax was very low actually, we decided that SMILE would be fine for this patient. And we did it, and the patient did very well for the first week, 2020, first year, second year after surgery. Third year, she didn't come, but she comes in the fourth-year follow-up complaining of decreased vision. And you see uncorrected vision has decreased, distance-correct vision with 20/25 with astigmatism. The fellow eye is doing relatively well, and you can see ectasia happening. Interestingly, when you see the 2016 topography, you can see some abnormality here that you should have paid some more attention. Fellow eye is doing okay, at least so far. The back of the cornea is very interesting that you should take a look. We should control the same best fit sphere for the pre-op, and you can see the difference change, and probably here should have paid more attention and asked the patient to come back in 6 months, maybe even earlier. But this patient was diagnosed with SMILE ectasia in the right eye, actually the first ectasia I have ever had in my laser vision correction. And this patient was not ectatic in the fellow eye, and I do believe that the epithelial thickness was very helpful. You see the epithelial hyperplasia pattern instead of the thinning that you had in the right eye. Patient was advised not to eye rub, follow the left eye, and of course do treatment to improve the ocular surface and not to rub the eye. And we decided to do a femtosecond corneal ring and on transepithelium cross-linking in the right eye. So the procedure was done with a Physimax for a corneal tunnel, and 1 out of 15 cases we have to extend the dissection with this spatula that I helped design in a Brazilian company. So we have to go in and do the dissection because I tried to put the ring first, and because of the sake of time, we have to cut up the video so that we extend the dissection, and after extending the dissection, it's pretty easy to go in and to implant the ring. So we put the ring in, and after implanting the ring, we unengage. The ring is in very quickly, and you can see the riboflavin intertunnel. So it's very important that we are careful when you inject something inside the eye and also inside the cornea. You have some resistance, you take it out, you flush it away so that you don't have an arrow inside of the eye that will extend like a nightmare, the problem. So this will be the technique that we use. We learned from Eileen Urton this technique a few years ago, and I would like to have some channels here, as Seiler published in IOVS, actually Seiler's son, a very nice technique for epi-on intra-channel with the femtosecond laser. But we inject in both sides, and then we do the UV with a fast protocol. This is the patient's 8 months after surgery, doing very well, happy with 20/40 uncorrected vision, now corrected to 20/20, and this is the ring in place. You see the differential map and also some evidence of cross-linking that we also can see in the biomechanical model. So what did I learn? I was looking back in the pre-op, and we didn't have the TBI at that time, but we had the data, and we were able to compute the TBI for the right eye is 0.72, the left eye is 0.25, and this is something we should take a look at as an evidence. Early today, we had an interesting paper from Hardy Shetty presented with a 0.35 TBI, and we should consider that as abnormal. It is a sign of susceptibility. We know ectasia is rare, but still occurs. We have to identify ectasia susceptibility. We're not looking for keratoconus. We're not looking for keratoconus pattern only. Of course, if the patient has keratoconus, they will have ectasia after surgery accelerated, but we need to look for susceptibility. The biomechanical impact from laser vision correction should be considered more deeply, and we are doing interesting studies on that. Eye rubbing is always an issue. Tell the patient not to rub the eye. Advanced color imaging also for post-LASIK ectasia detection, and the treatment should be done with the nice care that you should have for a patient. So it's a true revolution in evolution, and we can go from SMILE to Frown, and of course, back to SMILE again. Thank you.